Good evening, everybody. It really is an honor and a privilege to be invited here to speak, and I want to thank Tunjai for inviting me. I had this fantasy that Tunjai was going to be an old guy like me, but he actually looks like the American actor Ashton Kutcher, and I think he would fit in well in my son's punk rock band if he decides to have a second career. So one thing we've all shared over the past 2 years is the global pandemic. And this is only the second talk I've been given in person since the start of the pandemic, and getting used to traveling again. And but this is a terrific book about pandemics that actually was published about 5 months before COVID, coincidentally. And it's by a psychologist in Canada, and it's really worth reading. I think you'd quite enjoy it. So tonight I'm going to talk about what we know about gender identity development in children in general, and then talk about gender dysphoria in children and adolescents. And so we'll do the first part, and then we can take a 5-minute break and do the second part. So we start in terms of understanding normative development. These are the parameters we use to define biological sex, from the sex-determining genes down to the external genitalia. There is, of course, a lot of interest over the past 10 or 20 years in whether or not there is something that we could operationalize as brain sex, but that's not used in terms of our typical way of defining biological sex. Parameters of psychosexual differentiation, and this is sort of the overarching element of the first part of my talk tonight. We start with sex or gender assignment at birth, gender identity, gender role behavior, and sexual orientation. And one theoretical perspective that has influenced me for many years is what I'm calling here the normative sex difference or sex dimorphic model. So if we take these 3 parameters of gender identity, gender role, and sexual orientation, on average, there are large and significant sex differences between males and females on these 3 parameters. And I'll be talking about that as we go along. And then when we think about how to understand gender dysphoria, to what extent is the normative sex difference or sex dimorphic model useful? And are we really talking about 2 sides of the same coin? Classically, when we talk about psychosexual differentiation, we have a temporal sequence, gender identity developing first, followed by the emergence of gender role behavior or expression, and then the development of sexual orientation. And in this classical model, there's an assumption that these three parameters intercorrelate with one another. And theoretically, there is the idea that there are common underlying factors that are related to all three of these parameters. Not perfectly, of course, but there's an interconnection. A slight revision to the classical model is that it's not always clear when we look at empirical data, does gender identity always emerge first and then gender role, behavior, or expression? Is it the other way around, or is it a back and forth? But that's also something to think about. Basic definitions. Gender identity has been defined over many years as a person's subjective sense of maleness or femaleness. But in contemporary times, we can also talk about alternative gender identities that are neither male or female. And I'll go on to talk about gender role, behavior, and sexual orientation in a minute. Now, one element of all of this is asking about what we know about cross-cultural similarities and differences in these parameters. A lot of the research on this topic comes from the West, but there also has been a lot of cross-cultural research that is very important. So across a whole variety of cultures, it's been possible to identify people who don't fit into the male-female binary. And as a result, they are categorized as a type of third gender that occupies a liminal space between male and female. And I ran out of room on this slide, but this is an example of third gender labels across a whole host of countries. One of my colleagues has done a lot of work in Samoa on the Fafa Fafin, who translated into English, it means in the manner of a woman. And in Samoa, one can even identify biological males during their childhood, where they're sort of identified by their families as kids who are going to grow up and be a Fafafine. My colleague took a picture of these two young adolescent boys who will probably go down that gender developmental pathway. And so, in many respects, when we think about transgender individuals in the West, we can think about them as also occupying a third gender. And certainly in Western culture nowadays, there is so much talk about moving away from the gender binary of cisgender versus transgender, and there are all kinds of alternative gender identities nowadays that people declare for themselves. Non-binary, genderqueer, agender, gender fluid, and so on and so forth. And that great authoritative research source, Facebook, 8 years ago, identified 58 different genders that people could choose. And we also know that now in some countries and jurisdictions, people are able to mark their sex on passports and birth certificates as X instead of male or female. I'm noticing a little echo. Do you want to fix that a little bit, or should I stand further back? Keep going? Okay. So let's talk about assessment methods for gender identity and gender role. And there are basically four approaches that one can identify in the literature: parent report questionnaires, behavioral tasks, structured interview schedules, and projective tests. And these various measures have been summarized in the literature, and I'm going to just give you some examples. When we measure gender role behavior in children, there are at least 6 core areas that we look at: peer affiliation preference, toy and activity interests, roles children take on in fantasy play, dress-up play, activity level and rough and tumble play, and parental rehearsal play. And the key point I want to make here is that a long line of empirical research documents quite clearly that there are large, significant sex differences between boys and girls on these measures. So, for example, the developmental psychologist Eleanor Maccabee published a book in 1998 summarizing years of her research on how in childhood we have this concept of peer group gender segregation, that when you let children make their own choices, boys largely like to hang out with boys and girls largely like to hang out with girls. And as I'm talking about this, of course, there's always overlap, but the main point is that on average there are large, significant sex differences. A number of years ago, we developed a parent report questionnaire trying to get at both gender identity and gender role behavior in children. And this questionnaire has been used extensively since the original study, and so I'm pretty satisfied that it has good validity. Here's just one item example, and let's say the parent is rating a male child. In playing mother, father, house, or school games, he takes the role of, and it can range from a girl or woman at all times to a boy or man at all times. And when we did a factor analysis of the scale, 14 of the items clustered together in a quite reasonable way, so leaving the scale with a one-factor solution. Now, this is a slide showing the mean ratings of a large control group of both boys and girls that I included as part of our original research. So these are all kids who either were being seen clinically for some reason other than gender dysphoria, or they were siblings of gender dysphoric children, or they were community controls. And by inverting the score for one of the two groups here, just arbitrarily to make the point, you can see a huge difference in the ratings of boys versus girls, and using Cohen's D to calculate an effect size, you can see the value is 6.49, which is a really large difference. One of the tasks we used for many years was a free play observation procedure where kids are in a room, they're left on their own, they're told that while the tester is doing some work behind a one-way mirror, they can play with whatever they want. And then we record how much time they play with the stereotypical boy toys and girl toys. So we have Barbie dolls and baby dolls and dart guns and handcuffs. Over the years, I learned that it became harder and harder to buy dart guns because of anti-gun sentiment in Canada. So it became more difficult to find dart guns, which were actually a lot of fun. And then we have dress-up clothing, stereotypical masculine and feminine. And on this slide, I just want you to look at the bars for the control groups, which are labeled con girl, con boy, and on the left is the percentage of time engaged in feminine play, and then on the right side, the percent of time engaging in masculine play. And you can see there's a very strong sex difference in what, on average, girls chose to play with compared to the control boys. These kinds of findings, for example, the kinds of toys that children like to play with, are found in many countries and cultures. Now, interesting element of studies of sex differences in kids is whether there's a sex difference in color preference, which people talk about in relation to the stereotypes of pink and blue. So a number of years ago, we did a study in Toronto where we were looking at the color preferences of children with gender dysphoria and various comparison groups of kids, which I want to focus on here. And I came up with this creative idea of showing kids the color selection from PowerPoint. So we printed it out and we showed it to the kids and asked them to pick their 3 favorite colors from this display. And again, let's just focus on this slide, the group of clinical control boys, CC, and the community or normal control boys and girls, NC. So what percentage of the controls chose pink or purple as their first choice? And you can see that in the 2 control groups, the clinical controls and the normal controls, almost never was pink or purple chosen by the control boys, but was very commonly chosen by control girls. And another metric I used in the study was the mean number of pink/purple choices subtracted by the number of blue choices. And again, a clear normative sex difference in to what extent control boys and girls favored pink versus blue. And my observation in Western culture is that this pink-blue distinction is pretty common. You can see it all over the place, but is it universal? And the answer is not always. So Davis et al. Recently published a paper in Child Development where they looked at color preference of children from 3 cultures and countries where there was no exposure or very, very minimal exposure to Western media, etc. Kids from some villages in the Peruvian Amazon, kids from Tanna Island in Oceania, and then kids who are Bayaka forager families in the Republic of Congo. And they didn't find that there was a sex difference in these groups of kids. So the conclusion of Davis et al. Was that the very strong color preference we see in the West is not due to some innate biological factor per se. Now let's move on to sexual orientation parameters and terminology, because the terminology can be sometimes very confusing, but the way a lot of us think about sexual orientation is with regard to three main parameters: sexual orientation and fantasy, sexual orientation and behavior, and one's self-labeled identity. And there are different terms. So in the older literature, it would be homosexual, bisexual, heterosexual. Nowadays, one could add to that asexual or pansexual. And then, some people object to using the word homosexual nowadays because it's viewed as stigmatizing. So we can replace homosexual with androphilic, and we can, with regard to biological males, so if you're attracted to men, you're androphilic. If you're a woman and you're attracted to women, you're gynophilic, etc. And if you're a man attracted to a woman, you could say the man is gynophilic, etc., etc. And then if we think about sexual identity labels, the most common ones these days are gay, lesbian, bisexual, straight, sometimes fluid. Now, from an empirical point of view, how do we assess sexual orientation? There are different ways of doing it. One can rely on self-report. And the extent to which one relies on self-report in terms of the level of detail varies considerably from single item assessments to more detailed structured interviews. We also want to look at the concordance among self-report measures of fantasy, behavior, and self-labeling. A more complicated method of assessing sexual orientation is using psychophysiological techniques, penile plethysmography and vaginal photoplethysmography. Now, of course, in large-scale studies, you're not going to be bringing people into the lab and hooking them up to complicated devices and measuring their sexual arousal. But for laboratory research, psychophysiological methods are common. We also want to look at the concordance between subjective and objective measures. And over the last few years, there has also been some research seeing if one can identify fMRI correlates of sexual orientation. For many years, when we do fairly detailed, structured interviews to measure sexual orientation, we use the Kinsey scale where a Kinsey rating of 0 means you're classified as exclusively heterosexual, and if you get a Kinsey rating of 6, you're classified as exclusively homosexual. And when we do these interviews, we can assess sexual orientation in fantasy and in behavior. Now, if you think about these parameters of sexual orientation in fantasy, behavior, and identity, one of the things we've learned is that there is not perfect overlap among these 3 parameters in various samples. So one has to be very careful in assuming that if you're classified in one category for fantasy, you're also going to be categorized that way for identity. So they overlap, but not perfectly. Now we'll talk a little bit about theoretical and conceptual models of psychosexual differentiation. Back in the 1960s and 1970s, psychoanalysis and social learning theory had particular influence in thinking about normative psychosexual differentiation. Beginning in the 1970s, social constructionism and feminist theory played an important role in thinking about these issues. In the 1990s, we have the beginning of postmodernism and what's known as relational psychoanalysis became influential for some people. And also since the 90s, biology and neuroscience has become very important in theoretical thinking. Some of us try to sit on the fence and think about things from a biopsychosocial perspective, meaning that a whole variety of factors, both biological and psychosocial, are important. And if we think about some of the theorizing with regard to children and adolescents with gender dysphoria, which I'll talk about more in the second part tonight, there are a number of models. There's the biological or born that way model. Then there's the social learning or social constructionist made that way model. And then there are models that want to understand what's going on inside a kid's head, influenced by cognitive, developmental, and gender schema theory in developmental psychology. There continue to be psychodynamic formulations, family systems formulations. And then again, one way to think about it is that gender identity, psychosexual differentiation is influenced by multiple factors that develop over time. There's a whole line of biological research with regard to normative psychosexual development. I'm going to just talk about a few of them this evening, but there have been genetic studies, behavior genetics, Then there's prenatal sex hormone theory, the so-called organizational model, which we'll talk about. Behavior genetic studies have been interesting. So for example, this slide is looking at familiality, where one starts with two groups. So this is a slide involving women. So one group that is recruited are heterosexual women, and then another group that's recruited are lesbian women. And then you ask them, how many brothers and sisters do you have who are gay? So this slide is a combination of several studies in the literature, and you can see, looking at the two bars on the right, that if you started with a gay proband and asked her how many gay brothers and sisters she had, you can see the rate is much higher than if you started with a heterosexual proband and asked her how many gay brothers or sisters that she had. If you look at other studies where you're starting with either straight men or gay men, again, you find evidence for an elevation in homosexuality among the gay men compared to the straight men. So, which potentially, though of course not entirely, is suggestive of some type of genetic factor. Twin studies of sexual orientation are also interesting, but not entirely decisive. So about 30 years ago, my colleague Bailey published a study where he recruited both monozygotic and dizygotic twins, where they were recruiting gay men, this slide is women, sorry. So they're recruiting gay women who had a twin. And if you look at panel A on the left, you can see that among monozygotic twins, 50% had a lesbian co-twin, compared to only 15% of the dizygotic twins. Now that study was criticized in terms of how they were recruiting people, and there was concern that there was some selection bias. So Bailey did another study looking at evidence for concordance among monozygotic and dizygotic twins in a large Australian sample, and didn't detect a difference between monozygotic and dizygotic twins. So the literature is a little unclear. The original studies were suggesting a very striking difference, but less so in subsequent studies. Now let's talk about prenatal sex hormones. If you look at this figure and just look to the left of the time of birth, you can see that that prenatally males are exposed to a much higher level of testosterone. And this is in part related to a long line of research on animals, wondered about the particular importance of between-sex variation in sex hormone exposure. Back in the 1970s, when prenatal testing was enhanced by being able to assay information about the fetus from amniocentesis, various people started to report on prenatal testosterone levels, and when I was looking at this literature quite a while ago, there were about 40 studies, and you can see that these are just examples. They all are detecting very significant sex differences in prenatal T. This is one study where the effect size is 2.3. Another study, late in gestation, the effect size is 2.11. And I got some raw data from a psychologist who was collecting mid-gestational testosterone data for some research she was doing. And from just having the information on the prenatal testosterone level, I could classify 73% of the subjects as actually being chromosomal males, and could classify correctly almost 90% of chromosomal females. So variation in prenatal T is a very important element of biological psychosexual differentiation. And we know this in part from a whole series of studies on newborns who have what we call disorders of sex development or physical intersex conditions. So one such condition, in this case, we're talking about genetic females. We know that they're exposed to higher levels of prenatal testosterone, plus perinatal androgens, but the effect of this excessive exposure to prenatal T is that their external genitalia are ambiguous or masculinized. And depending on how masculinized the external genitalia are, sometimes at birth they're declared to be boys because of the appearance of the genitalia. But the more common situation is that the appearance of the external genitalia is ambiguous. So it's difficult to make a gender announcement at the time of birth without further diagnostic testing. Now, there are a whole variety of disorders of sex development where, for various reasons, the baby is assigned to be raised as a girl, even though they have been exposed to higher levels of testosterone than you would expect in an unaffected female. So this is a slide of a genetic male with partial androgen insensitivity syndrome, and some genetic males with partial AIS are raised as girls because there is only a very partial masculinization of the external genitalia. This is a slide of a genetic male born with penile agenesis. So at the time of birth, there's no penis. And the decision in this case was to raise the newborn as a female, so this is an image after the testes and scrotum had been removed. And then in the very rare instance of cloacal exstrophy, for example, in the case of in genetic males, there is no penis, or the penis is split in half. And in some instances, because there is no penis, the recommendation is to raise the infant as a girl. And if you look at a whole host of studies, including some that I've done, where we are looking at gender identity and gender role development in disorders of sex development, where the baby is assigned to be raised as a female, even though we know they've been exposed to excessive amounts of prenatal androgen, we can show that their gender role behavior, for example, is masculinized to some extent. So on this slide, if you just pay attention to the DSD group and the control group, so these are all DSD kids with some excessive exposure to prenatal androgen and are being raised as girls, you can see that they are more likely to engage in masculine or boy-typical play on that free play task that I showed you about. One parent report questionnaire that I developed many years ago, one dimension of temperament assesses activity level, which shows a very strong normative sex difference. So some item examples: she is very energetic, she is always on the go, she likes rough and tumble play. And again, if you look at the DSD column and the control column, the DSD kids show a higher activity level than control girls, potentially implicating again the role of prenatal androgens. So there's a whole line of biological research that suggests that these factors are important in understanding normative psychosexual differentiation. But we don't want to stop at biology. We also need to think about what do we know about psychosocial influences on psychosexual differentiation. And we can think about gendered socialization, internal factors in the child, which we call cognitive developmental, and then psychodynamics and family systems. So we can ask, do sex and gender matter? In North America, at least, you'll have to tell me how it works here, but birth announcements are very common in newspapers when parents of kids. What do the birth announcements say? They say something about the gender. They don't announce the hair color of the newborn, if the baby actually has hair. And some old studies from the 1980s showed that the majority of verbal comments made by parents shortly after the birth of their newborn pertain to its sex. And another study back in the 1980s found that 80% of initial questions by friends of parents pertain to the baby's sex. So I guess nowadays, you know, if you're in the hospital, your friends are going to text you and they're going to ask, so is it a boy or a girl, right? And we can ask circa 2022, you know, does sex and gender identity still matter? And in the West, I think that the contemporary gendered social scene is in a lot of flux and a lot of discussion about how children should or shouldn't be gender socialized. And to some extent, one could posit that, you know, all forms of gendered or non-gendered child rearing are social experiments of nurture, not nature. So in North America, one thing that's been very trendy are so-called sex/gender reveal parties. So you invite all your friends over and you cut open a cake, and depending on whether the baby is going to be male or female, it's colored, you know, pink or blue, and all of the associations with it. There's a very small number of parents in the West who actively resist gender socialization. So, for example, 11 years ago in Toronto, a story about one particular family made front page news because when the baby was born, not only would the parents not tell anybody whether their baby was a quote boy or girl, they wouldn't tell anybody if the baby was male or female. So they kept the child's biological sex concealed from their social network. And again in the West, in North America, it's been common for some families to openly declare that they're raising their child in a gender-neutral way, and so they're called theybies, T-H-E-Y-B-I-E-S, with the idea that parents will say, we're going to let our kid decide if they're a boy or a girl, or something else. And I saw a really funny cartoon the other day. I don't know if one always has to be careful in telling little jokes because it may not come across properly, but it's a photograph of two parents in the maternity ward, and they're holding the baby, and they look up at the doctor and say, so is it a boy or a girl? And the caption of the doctor is, well, we'll let the kindergarten teacher decide. Again, if we think about conceptual models of psychosexual differentiation, we have to think about the range of approaches that have been used to think about normative or typical gender identity development. So that's the end of part one, so maybe, do you want to take a 5-minute break? People can stretch. Okay, so the second part of the talk tonight will be talking more about gender dysphoria. And I thought just at the beginning, I'd make brief reference to where it's been placed in the nomenclature over the last 40 plus years. So the diagnosis of gender identity disorder first appeared in the DSM-3 in 1980. And it was in a section called psychosexual disorders, along with the paraphilias and the psychosexual dysfunctions. 7 years later, in the DSM-3R, it was moved to the section called disorders usually first evident in infancy, childhood, or adolescence. And so it was separated from the sexual disorders. Then DSM-4 and DSM-4-TR, 1994-2000, it was in a chapter called Sexual and Gender Identity Disorders. So back together with the paraphilias and the sexual dysfunctions. When I was chair of the DSM-5 work group in 2013, we had 3 sub-work groups, gender identity disorder, sexual dysfunctions, paraphilic disorders. And most of the people on the committee are my very good friends, except 1 or 2 maybe. But we decided we wanted a divorce from each other. So in the DSM-5, the sexual dysfunctions, the paraphilic disorders, and gender dysphoria all have unique chapters. And we can talk about why they were all lumped together to begin with. And the simple answer is American psychiatry really isn't interested in any of these 3 areas, and the people who work in these areas are just weird people, so they should just hang out together. We can skip that. Now, for people not familiar with the diagnostic criteria for gender dysphoria, there are distinct criteria sets for children versus adolescents and adults. So for children, one has to meet 6 of these 8 indicators to be threshold for the diagnosis, including A1, which reads a strong desire to be of the other gender or an insistence that he or she is the other gender or some alternative gender different from one's assigned gender. For adolescents, there are only 6 potential indicators, and you only need to meet 2 of the criteria to get the diagnosis. And I can say that these cutoffs, as part of the DSM-5 process, were not just pulled out of thin air, but justified by different data sets, which I don't need to go into tonight. Now, there is the International Classification of Diseases, as you all know, and in 2021, the diagnosis of gender identity disorder was first of all renamed as gender incongruence, but it was removed from the chapter on mental and behavioral disorders and moved along with the sexual dysfunctions into a new chapter entitled Conditions Related to Sexual Health. And maybe tomorrow in the all-day session, there might be some interesting discussions about what do people think about it being removed from the chapter on mental and behavioral disorders and into this new section called Conditions Related to Sexual Health. One interesting element of the ICD diagnosis of gender incongruence is that the ICD declares that you can't make the diagnosis until a child is at least 5 years of age, and there has to be a duration history of at least 2 years. And for various reasons, I find that for various reasons, I think that's very problematic. And certainly, this assertion was made without any empirical evidence to justify it. Now, there is a lot of research and clinical issues that are going on in the gender dysphoria field in the current cultural moment. And one could spend more than the time we have tonight to go through all of these. But I've listed on this slide 9 very hot topics that people are giving a lot of thought to. I'm going to talk about referral rates in a minute, but the other topics include the change in the sex ratio among adolescents who are being referred for gender dysphoria, from one that used to favor biological males to one that now favors biological females. I'm going to talk tonight about developmental trajectories or natural history. I'm going to talk a little bit about gender dysphoria and co-occurring mental health issues. Tonight I'm not going to talk about what seems to be a new clinical phenomenon, which some people are calling rapid onset gender dysphoria, but it's a new group of adolescents presenting for the first time with gender dysphoria in adolescence with no early history of gender dysphoria. And prior to the mid-2000s, we never saw kids like that. And now, at least in North America, maybe parts of Europe and the UK, we're seeing these kids everywhere. There continues to be some very interesting and important research on biological correlates of gender dysphoria. Tonight I'm going to talk about therapeutic models, best practice. And then there's also contemporary debate about informed consent among adolescents who want biomedical treatment. What actually is informed consent? And then there are legal issues. So, I mean, one big change in the gender dysphoria landscape is that everywhere one is seeing a huge increase in referred cases, particularly in adolescents. So in Toronto, in the old days, we didn't see very many adolescents. So back in the 70s and 80s and into the 90s, we always saw more children. But then in the mid-2000s, the number of adolescents started to increase dramatically. And people are seeing that everywhere. So this is a slide from the clinic in London, England. This was published in 2018. Just a massive spike in the number of referrals per year. Then this is a slide from an Australian clinic. So this change seems to be across many countries who are involved in the care of children and adolescents with gender dysphoria. And maybe we'll discuss, why has there been this huge increase? The next parameter that I want to talk about are developmental trajectories. So clinically, one can have referred to you a kid anywhere between the age of 2 and 12. That's my definition of childhood. I know it's not the World Health Organization's definition of childhood, but that's what I count as children. In Toronto, the mean age that we would see kids was around 7, but about 25% of the kids I would see in Toronto were 5 years of age or younger, including a few 2-year-olds. They were my favorites. And so one very important question that not only parents want to know, but we also need to understand it clinically and scientifically. What happens to these kids who present with gender dysphoria? How do they wind up? What happens to them? And nowadays, with rare exceptions, I don't show images of my patients because of you never know where they're going to wind up, even if they've given consent. So any image that I show is something I've taken off the internet. So this is a photograph of a very well-known trans person in the States called Jazz Jennings, who showed very early onset of gender dysphoria, wanting to be a girl, showing all of the gender role behaviors associated with that. What happens to these kids? And so when I write about what we know in terms of developmental trajectories, I use persistence and desistance. So persistence means that at the time of follow-up, the kid, now an adolescent or adult, continues to have gender dysphoria, whereas desistance means they no longer have gender dysphoria. And there have been around a dozen follow-up studies in the literature, some going back as early as the late 60s by solo clinicians. But the larger sample studies were done by colleagues in the Netherlands and what we did in Toronto, and by Richard Green at UCLA in the late 1980s. And we published our follow-up study of boys last year in Frontiers in Psychiatry. And what was fun about publishing it there is we paid out money to make it open access so anybody can read it. And you look at how many downloads you have and you think actually you've done something important because it's been like 100,000 downloads. So when you collapse across all of these studies, what do we know about persistence and desistence? Now, before summarizing the data, I need to talk about the therapeutic context of the follow-up studies. So these kids come into a clinic or they're seeing a solo clinician. What advice were they given? So in some cases, kids had an assessment, but no particular treatment. In other cases, one could say the advice given was not to do much one way or the other, which has come to be known as watchful waiting. In medicine, it's also called active surveillance. And then, perhaps more commonly, there was some type of active treatment. Recommendations given to parents to do in the day-to-day environment, behavior therapy, play therapy, psychodynamic psychotherapy, all kinds of things. So that was the context, the broad context of these follow-up studies. So persistence, if you look at these small, older studies, when you collapse across them, persistence was 9%. In Richard Green's study, 2%. In the two studies we did in Toronto, 12%. In one study from the Netherlands, for birth-assigned males, the persistent rate was 20%, which isn't that different from what we reported in Toronto. But in their study, 50% of the birth-assigned females were classified as persisters, whereas we only found 12% in Toronto. But the sample sizes in both studies were pretty small, so not sure I'd make too much about that. But when we look at our data from Toronto, it's very clear that the persistence of gender dysphoria of kids seen in childhood, so at around a mean age of 7, anywhere between the age of 3 and 12, and then followed up in late adolescence, adulthood, seems to be low. Now, another element of the follow-up studies is sexual orientation. And this is the title of Richard Green's book from 1987, called The Sissy Boy Syndrome and the Development of Homosexuality. And why did he call it that? Well, in terms of psychosexual differentiation, he didn't find much in the way of any persistence of gender dysphoria, but he found that, now this slide I realize is messed up. I missed that when I was going through. I have to ignore that weird white line. But in Green's study, when he assesses sexual orientation and fantasy, 80% of the feminine boys in his study were bisexual to exclusively androphilic, compared to almost none of his control group of boys. And he found the same thing for behavior. And when we look at, the slide's also a little messed up, sorry, but if we look at data from Toronto, follow-up study of boys, 2 metrics of sexual orientation from the Dutch group, and then a Green study, all find that at follow-up, a substantial majority of these gender dysphoric boys are bisexual or exclusively attracted to males. So in a sense, that is the more common long-term outcome. Now, I want to spend a little bit of time talking about some of the criticisms of the follow-up studies, because some people don't like to hear that the vast majority of kids in these follow-up studies lost their gender dysphoria. It bothers them for some reason. So one criticism is that there was method variance. So in the early studies, the rigor in which the outcome was assessed probably was not that great. But I would argue that the studies that Green did and the Dutch have done and we did were pretty thorough in our assessment. Then there's been criticism of, well, there are a lot of cases lost to follow-up. Though in our research, what we could show was that kids who we couldn't follow up, for example, they had moved and we couldn't locate them, or a few kids just didn't want to be in the study. We could show that in childhood, they were very similar to the kids who were in our follow-up study on a whole host of characteristics. So I didn't feel that the internal validity of our sample was threatened. Some critics haven't liked the Dutch studies because the Dutch counted as desisters kids who they weren't able to locate to come in for the follow-up study. And so the critics say, well, how do you know that they desisted? And the Dutch argument was, well, we're the only clinic in the entire country. So if these kids were persisters and wanted to come back and go on hormones and get surgery, we're the only game in the entire country. I thought that wasn't a bad comeback. And then an important criticism was that for those of us who used the DSM criteria for the diagnosis, it's pointed out that, well, not all of the kids in the follow-up studies met the complete criteria for gender dysphoria or the old diagnosis of gender identity disorder when they were seen as children. So there's nothing to desist from because they didn't have anything. Now I could make some counter arguments to that, but it's a reasonable criticism that can be addressed empirically. But what I like about this particular criticism is that it's a variant of the no true Scotsman argument. So person A says, no Scotsman puts sugar in on his porridge. Person B says, but my Uncle Angus is a Scotsman and he puts sugar on his porridge. And then person A says, but no true Scotsman puts sugar on his porridge. So we can address the no true Scotsman argument if we use the DSM criteria for the childhood diagnosis. And so this slide shows data from both Toronto and Amsterdam. And so here we have across these 4 studies, the 88 kids who were persisters at follow-up, and you can see that around 90% were given the complete gender dysphoria diagnosis in childhood. So that's pretty impressive. Then let's look at the 280 desisters, meaning they didn't have gender dysphoria at follow-up. And you can see that about 60% were threshold for the diagnosis in childhood. So my argument has been, well, it does seem that the cases who desisted didn't just include kids who were sub-threshold for the diagnosis. In fact, it included a lot of kids who were threshold for the diagnosis. So I'm not convinced that that criticism completely characterizes what the follow-up data show. Now, I was saying earlier that we have to remember the therapeutic context, so to speak, of all of the kids who were in these follow-up studies. And to a large extent, these kids were taking part in these studies, not entirely, but a lot of them, prior to the emergence of a very different approach designed to reduce gender dysphoria, which has come to be known as prepubertal gender social transition. So let's say a 3-year-old says, you know, I want to be a girl or I am a girl. The therapeutic approach is to go along with or implement or support or encourage the child to live in the desired gender. So parents might either on their own or at the suggestion of a clinician or a family doctor change the child's name if their birth name was stereotypically gendered, so change the name, start using different gendered pronouns, and that socially the child, let's say, goes to school in the so-called desired gender. And so that's a very different psychosocial or therapeutic approach to reduce gender dysphoria. And this has become a fairly common approach that some parents are taking, some clinicians are taking. Exactly what percentage of kids who are seen clinically have already adopted this approach, or what percentage is it recommended? We don't really know, because people can seek out so many different sources of healthcare. But a lot is being written now about prepubertal gender social transition. And I'd shown you that image earlier of Jazz Jennings, who many years ago as a teenager wrote a book about her life called I Am Jazz. And in this book, the sort of penultimate page is I have to see if I can read this on I need my glasses. I have a girl brain but a boy body. This is called transgender. I was born this way. And Jazz Jennings is sort of like a prototype example of a kid who went through an early social transition and persisted. And I, over the last few years, have written that once we actually see data on follow-up of children who have transitioned socially prior to puberty, my prediction has been that the rate of persistence will be way higher than in these older follow-up studies. And there's one psychologist named Christina Olson who's been following a large number of children who have transitioned prior to puberty and just published some preliminary follow-up data in pediatrics, where there were 317 children who had socially transitioned at a mean age of 6.8 years, entered her study at a mean age of 8.1 years. At a follow-up, on average, 5.4 years after the social transition, at minimum, there was a persistence rate of 94%, meaning they continued to live in the gender they had socially transitioned to. So you can see that that rate is way different from these older follow-up studies. And it raises lots of very interesting questions. In developmental psychology and psychopathology, there the concepts of equifinality and multifinality. Equifinality means that you start from different places, but have the same outcome. And one way of thinking about it, it's kind of an odd way to think about it, but let's say kids who were seen for gender dysphoria and didn't really have any treatment of any kind, then there were kids who had some kind of active treatment, leads to a high rate of desistance. Whereas, let's say the kids who have socially transitioned, you could say that they have a high rate of desistance as well, except it's come about in a very different way. So they no longer have gender dysphoria because they're now living in the gender they apparently desire to have. But the implications for those kids are going to be very different than these other two groups, because for them to remain desisters, they're going to need lifelong hormone therapy and surgery. But that's a topic for later discussion. Want to talk next about the co-occurring mental health challenges. And over the last, I would say, 5 or 10 years, there have been two domains that people have gotten really interested in. The co-occurrence with autism spectrum disorder. There's one study out of Turkey that looked at that co-occurrence, and then suicidality. This is a huge domain of discussion in North America. So 7 years ago, a couple of clinicians in the States made the assertion that completed suicides among adolescents with gender dysphoria are, quote, alarmingly high. That is pretty much an inaccurate statement, and they certainly didn't provide any data. But suicidality is as I'm going to show you, a very important clinical consideration that anybody working in the area has to take into account. There are measurement issues. For example, are we talking about self-harm versus bona fide suicide attempts? We have to think about samples, and are there comparison groups? One reason this became a hot topic was there was a survey of transgender adults in the US where they collected data on thousands of adults, and 41% said at least they had made at least one suicide attempt in their life. Now, you know, one of the problems in terms of sampling, completely non-representative sample of transgender adults recruited on Facebook or other social media sites, community organizations, etc. So you really have no idea who participated in that study. But virtually any article that talks about suicide will come up with this 41% figure. And sometimes I see patients where, you know, their parents will say, I read that 40% of kids with gender dysphoria kill themselves. And so you wind up spending a lot of time doing basic psychoeducation about what is out there. So the internet can be a very dangerous place in terms of people being able to accurately appraise what they're reading. But just to show you some examples, this is a nice study of high school students in the US asking about suicidal ideation in the past 12 months. Of the students who identified as transgender, almost twice as many reported suicidal ideation compared to non-transgender students. This is another nice sample of high school students asking about a suicide attempt in the past 12 months. And again, you can see in trans females, meaning they're born female, and trans males born male, those who report a suicide attempt is way higher than control females and males. So we see this data from high school samples of students. Now, there have been a bunch of clinic samples reporting on suicidality data in adolescents, where the percentages certainly seem elevated. But at the time we did our own suicidality study, one of my criticisms of these other clinic samples was nobody had a comparison group or a control group. So in our study, we looked at suicidality in 3 clinics, Toronto, Amsterdam, and London, England. We used a couple of metrics of suicidality from the Child Behavior Checklist and the Youth Self-Report Questionnaire. For those who work in clinical child psychology and developmental psychiatry, people know what these questionnaires are. And we used as comparison group the norm data on referred and non-referred youth. So we do have some comparison data. And I'll just show you what it looked like. So this is showing data for those assigned female at birth. This is parent report. Kid talks about killing themselves. And you can see that in all three gender clinics, Toronto, Amsterdam, London, the percentage is way higher than non-referred adolescents, but pretty similar to adolescents who are referred clinically for any mental health issue. This is self-report, talks about killing self. Again, way higher than non-referred kids, but certainly within the range of what one sees in referred kids in general. Then the item deliberately harm self or attempt suicide, again, compared to non-referred kids, elevated. The London clinic, it's way higher than the referred kids, but in Toronto and Amsterdam, more similar. And then the same thing for deliberate self-harm. So, I skipped that. So, do adolescents referred clinically for gender dysphoria have elevated rates of suicidality? Absolutely, when compared to non-referred, presumably cisgender adolescents. But the elevation in suicidality, I think, is pretty similar to what one would see among adolescents who are being referred for any type of mental health issue. So I don't think it's unique to adolescents with gender dysphoria. And what we found in our study was that the best predictors of suicidality included, interestingly, more recent year of assessment, because some of these data points went back to the 1970s, elevated among females, assigned females at birth, a rating we had of poor peer relations, and also number of behavior problems in general that these kids had. In fact, that was the strongest predictor of an elevation in suicidality. So my point is that, you know, suicidality shouldn't be looked at in some type of vacuum. It's really part of a broader range of factors that are correlated with suicidality. Sure, having gender dysphoria may be one factor that is unique in terms of leading to suicidal thoughts or behaviors, but it's also in the context of having other mental health issues. So, you know, clinically, one needs to take that into account. Okay, the last topic I'm going to talk about tonight are best practice therapeutic models and their conceptual underpinnings for children and adolescents. And again, in thinking about these best practice models, one can also think about, you know, what is the theoretical and philosophical perspective, not only of the clinician, but let's say of parents. How do they understand the gender dysphoria? Because one could argue that whatever approach one takes, the goal is to reduce gender dysphoria one way or the other. And I've talked already tonight about how in children, you know, there have been different approaches to reduce gender dysphoria. You know, with regard to children, over the years, there's a lot of debate about what is the best practice, and various organizations, including the American Psychiatric Association, the American Psychological Association, have done these big reviews of the literature. And what they note with regard to children is that one has to be very careful in making a declaration as to what the best therapeutic approach should be. So this is a practice parameter from the American Academy of Child and Adolescent Psychiatry, and I'll just read you their conclusion. Different clinical approaches have been advocated for childhood gender discordance. There have been no randomized control trials of any treatment, which is true, and it still is true. The proposed benefits of treatment to eliminate gender discordance must be carefully weighed against possible deleterious effects. This is the American Psychiatric Association. Very few studies have systematically researched any given mode of intervention with respect to an outcome variable in gender identity disorder, and no studies have systematically compared results of different interventions. In light of the limited empirical evidence and disagreements among experts in the field, recommendations supported by the available literature are largely limited to the areas of consensus identified earlier in the review, and would be in the form of general suggestions and cautions. So, basically all of these reviews have said the evidence out there to advocate in favor of one approach over another is pretty limited based on actual data. So that's where things like clinician ideology or theoretical bias can come into play. And I think that that's also true for parents, because it's not surprising that parents might look to see a clinician who shares their own worldview. So sometimes, I say, let's say an adult is depressed, and let's say that person wants medication. They're gonna, and no talk therapy. So they're gonna look for somebody who's gonna put them on an SSRI. Then there are gonna be other people who don't want medication at all. So they're gonna look for somebody who will do some type of talk therapy with them, CBT, mindfulness, psychotherapy, etc. And then there are going to be other people who want both. So where it's feasible, you find somebody who shares your own perspective. Here's another joke I'll try on you. One joke, when I can, I do long-term psychotherapy with my patients, and or the parents of my patients, and I say the main goal of the long-term psychotherapy I do is to get them to agree to go on medication. I don't know if that translated, but I once was seeing a child patient who is now an adult, and I saw her for 10 years, and I think in year 9, she finally agreed to go on escitalopram, and she said, "Why didn't I listen to you like 8 years ago? Like, I feel so much better." I said, "You're stubborn." Anyways, so briefly, when it comes to children, one of the rationales for the older therapeutic approaches is that if it's successful, it avoids the psychosocial and biomedical complexities of gender transition and sex reassignment surgery. And I would say that, the underlying philosophical assumption that these approaches have is that although there may be predisposing factors, there's not an adoption of the born that way model, and that there's more malleability and plasticity in gender identity differentiation in children. Alice Drager, who writes about medical ethics and is a medical historian, has called this approach the therapeutic model. I like to call it developmentally informed psychotherapy. Now, we've also talked about a little bit the new gender affirming model, where if you look at its deep structure philosophical assumptions, there's an adoption of an essentialist perspective. And people who adopt this model don't even like the diagnosis of gender dysphoria, except maybe to get insurance reimbursement. So there are these different approaches. Now, let's talk about adolescence, the final part. What are the best practice treatments? Now, for adults, I think until very recently, with a new subgroup of patients that people are seeing, if somebody came to a clinician as an adult and they had gender dysphoria, I think the best practice treatments are to support or encourage a gender social transition, to support or recommend contrasex hormones and sex reassignment surgery, on the grounds that for the vast majority of adults, there's no indication that there's going to be remission without these kinds of treatments. With adolescents, so who are in between children and adults, a common approach currently is to support or recommend a gender social transition, to recommend that the adolescent go on a GnRH analog to delay or suppress somatic puberty, and then later on, if there continues to be persistence, contrasex hormones, and then later sex reassignment surgery. Now, I would say that this is a pretty common approach to reducing gender dysphoria in adolescents. But I can skip this slide. But there is one caveat I would make to that, which is that not all adolescents with gender dysphoria who come in to be seen clinically want biomedical treatment. They'll come in and say, I need to talk to somebody because I'm confused about myself. I don't know if I should be a boy or a girl or something else. I'm having a hard time. And so I think for these youth, one should not rush into or push biomedical treatments, but give them therapeutic space. That's one caveat. And then a second caveat is some adolescents with gender dysphoria have pretty severe co-occurring psychopathology. And one could make the argument that these kids require extended evaluation and treatment before making decisions about the potential benefit of biomedical treatment. And if one, works in the gender dysphoria area, and let's say you see a dozen adolescents, you'll see that, a good 2/3 of them have pretty significant co-occurring mental health problems. There are, of course, some who are doing quite well in a general way, but one really has to be mindful that for the majority, I would say, of adolescents with gender dysphoria, there are other things going on that has to be thought about in terms of a treatment approach. Now, it's very hard to actually summarize what we know about persistence and desistance among adolescents who come in for the first time when they're adolescents. But for the sake of argument, let's say about 75% don't lose their gender dysphoria, either via talk therapy or spontaneous remission. The gender dysphoria remits only after the social migration to the desired gender, hormonal therapy, and or sex reassignment surgery. And there are some good studies, particularly ones from the Dutch group, that suggest that carefully evaluated adolescents do well with this care pathway. Now, a lot of the Dutch studies were written a while ago, so I'm not sure how many people actually have read them nowadays, but in their clinic, they recommended biomedical treatment after their initial assessment for about 2/3 of their patients. So that means a lot were not recommended this at the baseline assessment. And that's what we found in Toronto too when we started to think about putting kids on blockers. So we need to know a lot more about, well, who are these kids where we're not recommending hormonal suppression? What are the reasons? And we need more cross-clinic comparative studies on this issue. And nowadays we're actually beginning to see more adolescents who abandon this care pathway and they detransition. So they have started to live as the desired gender, but then they change their mind, and we need to understand better who they are. And just going back to the mental health vulnerability issue, we published a study in 2016 and we coded for the presence of 15 vulnerability factors in 50 consecutive referrals. And we found that the mean number of variables coded as present was 5.56. The mode was 8. And so the argument we were making in that paper is that there's so much attention given to the idea of hormonal suppression. Are we losing sight of the fact that a lot of these kids have other mental health issues that they need support for? So if you think about adolescence in terms of treatment pathways, you start with an assessment and diagnosis. One could recommend therapy, but no biomedical intervention, or you could recommend therapy with hormonal suppression, et cetera, and if there is persistence, one eventually might refer an adolescent for gender-affirming surgery. Now, one of the hot topics is how old the kids have to be before they can go on hormones and get surgery. And the World Professional Association for Transgender Health is more of the perspective, the younger the better. So later this year, they're going to be issuing revisions to their standards of care, and they're now recommending that children can go on cross-sex hormones as young as age 14, whereas in the old days, the typical age was, 16. And they're now going to be recommending bilateral mastectomy for birth-assigned females as young as age 15, whereas in the older days there wasn't a particular age at which one could recommend a mastectomy. So they're moving the age of eligibility down, which it'll be interesting to see how that lowering is received. So that's it. Thank you very much.